Welcome. Welcome to our session today. Welcome to the WeMove Adolescent Health webinar. It's hosted by Desmond Tutu Health Foundation and IAVI. My name is Jessica Amanda. I head the policy research and country support at the African constituency for the Global Fund. Thank you again for joining us today. We're in for a very interesting 90 minutes. We're looking forward to an interesting and interactive session. You know, this is the second webinar in this third WeMove series. And today, we're going to be discussing health economics, the price of adolescent healthcare services. Why is this topic interesting? Why is it important? Well, just a couple of startling statistics. In Eastern and Southern Africa, adolescent girls and young women, so age group 15 to 24, account for about 10% of the population, but they represent 25% of the new HIV infections. Generally in Sub-Saharan Africa, more than 50% of rural young women, so this again, age 15 to 24, have been pregnant before their 18th birthday. Those numbers are UNAIDS numbers. So it really highlights for us the importance of focusing on this age group. We will hear today from Dr. Neilan and Dr. Gesine Meyer-Rath. And in between, we'll have an artistic interlude just to keep things interesting. The interlude is from Hope Minies. Then we will have a panel discussion where our speakers will be joined by Professor Lungiswa, Nkonki, and Cheryl Hendrickson, and a PhD candidate for this discussion. So the first topic, health economics, the price of health services. We'll listen to Dr. Neilan. And then again, as we say, second topic, cost effectiveness and impact of scaling up adolescent health service by Dr. Gesine Meyer-Rath. To start off, we'd like to know a little bit more about what you think. And for that, to make things interesting in a well-organized structure, let's have a quick poll question. So please look out for the poll question. You can see the first statement is universal health coverage is about ensuring that people have access to healthcare they need without suffering financial hardship. True or false? Can you see the poll on your screen? Yes, I can see. Okay. So please let the vote come in. And then there is a second statement. I'm not sure we have to vote on all three now. Yes, the statement two. The statement two is on. SDG 3 target aims to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, access to safe, effective, quality, and affordable essential medicine, and vaccine for all. The goal includes adolescent healthcare service. True or false? Are adolescents included in this SDG 3? And then the third, access to affordable, quality primary care is the cornerstone of UHC. But many young people around the world still struggle to fulfill their basic healthcare needs. True or false? Are you voting? Yes. So the results are coming in. Statement 1, 98% vote yes, sorry, true, and 2% no. Does universal healthcare ensure financial protection? The answer is true. The second one is also true. And 95% of people said yes. And then the third, 100% say yes, access to affordable, quality primary health care is the cornerstone of UHC, and many young people around the world still struggle to fill their basic healthcare needs, sadly true. Okay, so now that the poll are in, let's listen to our presenter. Thank you. Dr. Anne Neilan. Let me introduce you briefly. Dr. Anne Neilan is the Assistant Professor of Medicine at Harvard Medical University and pediatrician at Massachusetts General Hospital. Her research interests include simulation modeling to inform policy-relevant care strategies for adolescents and young adults with HIV and at risk of HIV. Let's listen to Dr. Neilan, please.
Thank you for inviting me today. It's a pleasure to be here and to participate alongside Drs. Meyer-Rath and Amanda. I trained in pediatrics, adult medicine, and adult infectious diseases, and my clinical and research focus on adolescents with and at risk of HIV, so I'm particularly delighted to join this adolescent focus session. I have no disclosures. First, I'll discuss some of our published work on a hot topic, the cost effectiveness of long-acting injectable HIV pre-exposure prophylaxis, so with an adult focus in the United States. Then I'll discuss the role of simulation models to improve care for adolescents and adults affected by HIV. As this audience knows well, new long-acting prevention options are very common for prevention. Medications injectable every 1 month can improve adherence, but are more costly than pills. Recent landmark clinical studies generate and inform 70% efficacy of long-acting injectable hepatitis among middle-sex men and transgender women, and those for among adolescents and adult cisgender women.
Sorry, we can barely hear Dr. Neilan. Can we do something in the technical room, please?
We will be on it right now, if you mind giving us a few minutes.
Okay. Thank you.
I have the right presentation up here. Okay, sorry about that technical issue. So I think I stopped with, I have no disclosures. So first I'm going to discuss some of our published work on a pretty hot topic, the cost effectiveness of long-acting injectable HIV pre-exposure prophylaxis, but with an adult focus and in the US. And then next I'll discuss the role of simulation models to improve care for adolescents and young adults affected by HIV. And I can't see the chat while I'm speaking, so if for some reason the sound is off, if you can please just somebody interrupt me. Okay, we'll go to the next slide now. So this audience knows well that new long-acting HIV prevention options hold great promise for prevention. New medications, injectable every 1 to 2 months, can improve adherence, but are more costly than pills. Two recent landmark international studies, HPTN-083 and HPTN-084, demonstrated the superior efficacy of long-acting injectable cabotegravir, or CAB-LA, compared to oral PrEP. HPTN-083 among men who have sex with men and transgender women, and 084 among adolescent and adult cisgender women. So as new PrEP modalities emerge with distinct efficacies and prices, a key question we've been considering in our research is, how much are new prevention options worth in the US and elsewhere? And a more effective intervention is usually more costly than its alternative. And cost effectiveness analysis allows us to ask, is that additional benefit worth the additional cost? So in cost effectiveness analysis, 2 different outcomes are measured or projected. Cost is assessed in dollars or other currency, and effectiveness is measured in life years or quality adjusted life years. Once you have both of these measures for all the programs or the treatments you're going to compare, you create an incremental cost effectiveness ratio, or ICER, with incremental costs in the numerator and incremental health benefits in the denominator. There are other measures which combine these outcomes, but for the results I'll show you in this brief presentation, we'll focus on the ICER. Those results are discounted to reflect that health and investments are valued more highly in the present than in the future.
Dr. Neilan, please allow me to interrupt just a second. Can you just change it so that we see the main screen and not your notes also? And the next slide?
That would be great. Let's see. Thank you. How's that?
Yes, perfect. Thank you.
Okay. Awesome. Thank you. All right. So, right. So we were here where we were saying that the results are discounted, and that the ICER is a measure which combines those cost and economic outcomes. And once you've combined them for all the measures, you create this ICER. And then the lower the ratio, the more cost effective the intervention. And that threshold is a normative value, which is a source of considerable debate in pretty much every setting, or in most settings. And in the US, the threshold of $100,000 per quality has been commonly considered an acceptable return on investment. Simulation models are uniquely suited to conducting cost effectiveness analyses, or health policy models, as they're sometimes called. They can project outcomes beyond the horizon of traditional studies. They can also combine data from multiple sources and compare strategies where trials would be unfeasible. Since 2014, I've worked with my research mentors, Andrea Ciaranello and Kenneth Friedberg, using the cost effectiveness of preventing AIDS complications, or CPAC model, which is a detailed model of HIV disease testing and treatment, which has contributed evidence to inform US and international HIV policy for over 25 years. And you can see the citations of some of our faculty on the bottom right. We used the CPAC model to examine the cost effectiveness of long-acting HIV pre-exposure prophylaxis in the US, and our objective was to identify the highest price premium CAB-LA could command relative to oral PrEP under the most favorable conditions for LA PrEP. So in other words, what would we be willing to pay even in a best case scenario? And we examined 4 strategies for men who have sex with men and transgender women in the US: no PrEP, generic oral PrEP, branded oral PrEP, and CAB-LA. Model projected outcomes included averted primary HIV transmissions, quality adjusted life expectancy or QALYs, costs, and incremental cost effectiveness ratios. And we considered these clinical benefits and costs over a 10-year horizon. We estimated that the maximum price premium at which CAB-LA would remain cost effective below a given willingness to pay threshold. And for the results that I'll show, we took the price of CAB-LA at which CAB-LA would pass just below a $100,000 per QALY threshold, and then subtracted the cost of oral prep. So if the maximum price premium is lower, we would be willing to pay less for CAB-LA, and if the maximum price premium is higher, then we would be willing to pay more for CAB-LA. We used trial and published data to populate the model, including no PrEP HIV incidence of 5.3 per 100 person years, generic and branded oral PrEP HIV incidence of 1.3 per 100 person years, and CAB-LA HIV incidence of 0.3 per 100 person years. Generic oral PrEP price was $360 annually in the US, which is an order of magnitude lower than the branded oral PrEP price, which was modeled as $16,600 annually in USD. The price for CAB-LA had not yet been announced at that time, and so we used $25,800, a number based on pricing for CAB-LA in combination with other medications for HIV treatment in the US. And then the cost of ART annually ranged from $32,000 to $69,000 USD. Turning now to those results, over the 10-year modeled horizon, total transmissions were highest for no PrEP, 178,000, lower for each of the generic, oral, and branded PrEP strategies, 122,000, and then lowest for CAB-LA, 107,000. Averted HIV infections and primary transmissions led to the highest QALYs for CAB-LA, 4,654,000. Costs totaled $31 billion for no PrEP, $33 billion for generic oral PrEP, $60 billion for branded oral PrEP, and $76 billion for CAB-LA. Despite fewer side effects, branded oral PrEP would cost more per QALY gained compared with other options, which we call dominated. And I hope that is right. Yep. Okay. We compare the cost and benefits of CAB-LA to generic oral PrEP at 10 years and found that the ICER of CAB-LA would be $1.6 million per QALY, which is really well above any commonly considered cost effectiveness thresholds. So this figure is a sensitivity analysis on PrEP drug price for oral PrEP and CAB-LA. And the vertical axis shows annual price of oral PrEP from 0 to $20,000. The dashed horizontal blue line at 16,800 shows branded oral PrEP price, and that solid horizontal blue line just above the x-axis at 360 is indicating the generic oral PrEP price at $360. The horizontal axis shows annual drug price of CAB-LA from 0 to $30,000, with that vertical white line indicating the CAB-LA base case price. The green area indicates where CAB-LA would be cost saving using that threshold we picked. Yellow, where the ICER would be less than $100,000 per QALY, and red, where CAB-LA wouldn't be cost effective by the way we defined it. The square at the intersection of the solid lines shows the result where the price of oral PrEP is $360 and the price of CAB-LA is $25,850. And so at this point, CAB-LA would be in the red zone and would not be cost effective. However, if CAB-LA price was $4,060, then CAB-LA would fall just below that $100,000 per QALY threshold in the yellow zone for a maximum price premium of $3,700 above oral PrEP. I think, I'm hoping on the viewer end, you can see some of the animation. It's coming out a little fuzzy on my end. So I'll keep going, but please interrupt me if something doesn't map with what I'm saying. If CAB-LA was $2,260, then CAB-LA would be cost saving with a price difference of $1,900. So from that analysis, we concluded that CAB-LA should be priced to compete with generic rather than branded oral PrEP, and that the availability of effective alternatives, i.e. oral PrEP, limits the additional price payers should be willing to pay for CAB-LA as PrEP. So the price of CAB-LA was announced after that analysis was accepted, and it's more than 3 times what we estimated would be cost effective. And so this raises concerns that the most vulnerable populations who need this new modality most may have challenges accessing it. Impact is always hard to measure because the price has only dropped marginally in the US recently, but it was cited locally in our hospital systems formulary review. It was presented to USAID, featured in the UNAIDS global report, presented to the Bill and Melinda Gates Foundation, and cited in the 2022 World Health Organization guidelines. So I'm going to pivot now to talk about the role of simulation models to improve care for adolescents and young adults affected by HIV, which is something I've been working on for the past, I guess, 9 years now. So excited to chat a little bit about it. So why develop an adolescent and young adult focused HIV simulation model? And again, this audience which is focused on adolescence is probably well aware that adolescence is a distinct developmental time period, and that neurobiologically, there are rapid changes in brain myelination during the teens to late 20s, which are really quite distinctive. And during this period, the development of the limbic system, which is responsible for our emotions, for the gas on the car, outstrips that of the prefrontal cortex, which is responsible for reasoning, kind of the brakes on the car. And developmentally, this time is marked by initiating intimate relationships, developing one's own identity, establishing autonomy from parents, mastering abstract thought, having new educational and employment experiences. And in this period, rebellion, risk-taking, sensation-seeking, these are all normative behaviors. It's what we would expect. And so on the backdrop of this developmental period, it's quite challenging for adolescents to experience any chronic illness, let alone one that's compounded by the stigma associated with HIV still in most settings. Or if the normal behaviors one are engaging in places one at increased risk for acquiring an infection. So this slide shows that adolescents and young adults with HIV in the US have poorer HIV care continuum outcomes compared to adults, with the data for everyone 13 and older in blue, and then the data for the adolescents in peach. And so you can see at each step of the care cascade, living with HIV diagnosed, linked, retained, virologically suppressed, there's a big step off for adolescents and young adults. With ultimately only 35% virologically suppressed if we can consider a denominator of all those who have HIV. And so those who are undiagnosed or who are not virologically suppressed miss opportunities for treatment and improved individual health, and also may contribute disproportionately to HIV transmission. In the US, the CDC estimated in the US CDC estimated in 2019 that the highest rate of onward transmissions by age arises from adolescents and young adults with HIV, 5.1 per 100 person years. So we've developed in the US, in the CPAC model, a US focused adolescent simulation model that tried to ask questions that would be geared at some of those elements of the care cascade. So some of the examples of analyses that we looked at are, what is the life expectancy of youth with perinatal and non-perinatal HIV in the US? And that's just looking at clinical outcomes. What is the clinical and economic impact of COVID-related interruptions on youth with HIV in the US, which looked at cost and economic outcomes. And then we used we looked at cost effectiveness analyses as well. And we looked at what age should youth without identified risk factors be tested for HIV in the US, or how frequently should young men who have sex with men who would be at higher risk of HIV be tested for HIV? And what are the effectiveness and cost thresholds for ART adherence interventions with youth with HIV, and whether daily oral PrEP would be cost effective for young men who have sex with men in the US. So we developed this simulation model to answer questions like those with adolescent-specific health engagement patterns and outcomes reflected in both the structure and the data inputs, with age-stratified HIV incidence and screening, with support from NICHD and the Adolescent Medicine Trials Network for HIV/AIDS interventions. more recently, we've had the opportunity to start collaborating with DTHF to examine novel HIV prevention and treatment modalities and packages of interventions as they arise. And I think it's a really exciting time to think about these methods. They are methods to assess value and project policy impact. They're in high demand. At the bottom there, you can see cost effectiveness publications by year. I think starting in about, looks like 1988 all the way up to 2020, so it's probably even higher now. And I think these can be a really valuable tool to think about how we can both answer questions about care strategies for adolescents and also to advocate. So some of our early work with the DTHF will be at IAS this year. We're looking at long-acting HIV pre-exposure prophylaxis among adolescent girls and young women in South Africa, asking cost-effective at what cost, thinking about the individuals who would enroll in the FAST PrEP program, which Melissa and many of you are involved in. And so look out for the oral abstracts at the pediatric HIV workshop and IAS as well. So in conclusion, simulation models can play a key role in adolescent HIV healthcare and policy, and they can build upon observation and clinical trial data to provide evidence to inform the value of new interventions and the impact of health policies. Adolescent-focused HIV simulations modeling can provide critical evidence to address some of the substantial disparities in health outcomes for these populations in the US and globally. I'd like to acknowledge the CPAC Pediatric Research Group, as well as collaborators at DTHF and the Adolescent Medicine Trials Network for HIV/AIDS Interventions Modeling Corps. Some of us are pictured there. That photo is a few years old now, as well as our funders. Thank you.
Thank you. Thank you so much, Dr. Neilan. We have, maybe I can ask you just one more small question before I give the floor to the artist. And it's not exactly on the research, but the 95, that cascade for adolescents is so low that we're just wondering, what can we do better?
You know, it's so exciting to see so many people on this webinar. It is quite striking how the health outcomes for adolescents and young adults are so low. Specifically in the US setting, I think there's if we looked at that cascade also by minors, so those less than 18, and really the age of majority and consent varies by state in the United States, so it's really quite complicated. The individuals who are the youngest are really sort of disproportionately burdened and yet have very little access to prevention and treatment modalities. So, I think one of my particular interests is focusing on the youngest individuals who don't hear about it enough and also really are quite restricted by both specific state laws and also by confusion about what those laws are because they're constantly changing. So I think I have more questions than answers, but very enthusiastic to participate today and hear what other speakers have to say. Thank you.
Okay, thank you. Thank you. We'll give the floor now to the artist just to give us a small 5-minute entertainment. Thank you. Volume, please. Yes. It's now here. Volume. Go ahead. Please. Thank you. So the volume, I don't know if it's only me. I can't hear her. Okay, so 100% volume. Well. The volume decided not to cooperate yet. Maybe we'll try one more time. If not, okay, let's then move to the next panelist while we're trying to fix our volume. So allow me to please introduce our next panelist, Dr. Gesine Meyer-Rath, is the Associate Research Professor at the Center of Global Health and Development, Boston University, and a member of the VITS Health Consortium. She's a physician, health economist, and infectious disease modeler with experience in economic evaluation and healthcare intervention. She also works on the economics of HIV intervention, including antiretroviral treatment and HIV prevention intervention in resource-limited settings. Her presentation is the cost effectiveness and impact of scaling up adolescent health service. Please, let's listen to Dr. Gesine Meyer. Thank you.
Thanks so much, Jessica, for the introduction. Let me bring up my on screen. Okay. So I'm presenting our work on the cost effectiveness and impact of scaling up adolescent health services on behalf of my collaborators, Lisa Jamieson, also from HERO, and Lee Johnson from CIDA at the University of Cape Town. This work has been funded mainly by our USAID grant from USAID South Africa, our evidence grant, as well as a grant to Lee and me from the Bill and Melinda Gates Foundation called Lungiswa. Our collaborators here are mainly the National Department of Health, on whose behalf we're doing this work, SANEC, as well as UNAIDS. HERO's work on adolescent health services, very similarly to what the previous speaker has presented, really focuses on HIV services as well. And in particular, I'll be presenting cost effectiveness analyses for South Africa of oral PrEP, injectable PrEP, and the youth condom. Our methods, and I'll say this just in one slide, are very similar across all these analyses, and again, very similar to what Dr. Neilan presented just now. We model the cost effectiveness and impact of whatever HIV intervention we're looking at compared to that of the existing South African HIV program over a 20-year time horizon. We could be modeling for much longer periods of time. Roundabout now, that takes us to the early 2040s. We use for this a deterministic compartmental HIV transmission model, so not an agent-based model such as the CPEC model that Dr. Neilan presented on. Our model is a specifically South African model made by Lee Johnson at the University of Cape Town. It's called Tembisa, and has been used for the last 15 years to inform South African policymaking as well as budgets, etc. For each of those interventions, we assume different scenarios of uptake and coverage, as well as where need be effectiveness, and we look at different target populations. And of interest here is that for almost all interventions, we include adolescent girls and young women, as well as adolescent boys and heterosexual young men. Again, that's the age bracket between 15 and 24 years, as well as female sex workers and gay men and other men who have sex with men, and other populations as needed. Our cost, and that's specific to HERO, is always based on real world resource use collection, data collection. HERO employs an entire armada of data collectors that go into clinics and or into the community wherever needed, and collect this data meticulously in order for us to be able to build up costs from the bottom up in a micro-costing exercise. However, this we can't do for new interventions, such as injectable PrEP, where we do ingredient costing, where essentially we work with experts to build up a list of ingredients that will be needed for a new intervention, arrive at quantities, and then use the most recent public sector prices and salaries to come up with a potential cost of this new intervention. So I'll walk straight to my final finding here before I go into details on the individual interventions. What's important is that all of our data feed into one final analysis, which is the HIV investment case for South Africa, which we update annually and have been running since 2014. here we look at the cost effectiveness of all HIV interventions to answer the question of how South Africa should be spending its HIV budget, bearing in mind that 85% of the South African HIV expenditure is borne by domestic resources. So in other words, South African tax money is being spent rather than, as in other high HIV prevalence countries, mostly by donors. So for South Africa, what we then term allocative efficiency, so the most efficient way of allocating your limited resources is really very much a domestic question rather than one of the opportunity cost of other people's money, as it were. We do this, as I said, annually. This is the latest. We're right now busy with the 2023 update. This is the 2021 one. I don't think things will change a lot. But what's important here is that if we rank our interventions strictly by cost effectiveness, we see that adolescent interventions, such as testing for adolescents and further down different PrEP interventions, and this is oral PrEP in this case, are not the most cost-effective interventions to be spending South African HIV budget on. They are trumped by improving condom distribution and uptake, ART testing of infants at birth, PrEP for gay men, as well as HTS to the general population and medical male circumcision. And that's before the first adolescent intervention or specific intervention rolls around. Why do we think that's the case? Let's look at the intervention cost effectiveness in more detail. Firstly, we're looking at the cost effectiveness of oral PrEP, and in particular, whether or not self-selection of individuals based on their own perceived HIV risk will improve the cost effectiveness of oral PrEP. This is an analysis we did a couple of years ago, and basically working off the premise that, as we know, oral PrEP in the combination of tenofovir and emtricitabine is 65 to 85% effective based on the trial data at that stage. The cost in South Africa of oral PrEP is probably as low as it will get because it's already generically manufactured, has always been, and that's the case for most antiretrovirals generally in South Africa. And we're already producing huge and buying huge volumes of it, as both emtricitabine and tenofovir are also part of standard first-line ART. So there isn't, additionally, it's being rolled out still at the facility level, but there at by the lowest possible cadre of people, and the visits are as low as they need to be. So it is a fairly cheap intervention. Sorry, it's not a cheap intervention, but it's an intervention that's already made as cheap as possible. We are still, and this here we assumed an possible 1.5 years of oral PrEP use for everyone who started, which we have updated since. But at that stage, we were looking at around about $130 per person per year for the first year, slightly lower for the second year. And most of that was made up, or a good third of the drugs, another almost third by the labs. And even though we included social mobilization and M&E and all kinds of other overheads, they only made up the last third. Now, what does it do in terms of the impact on the HIV response? In South Africa, and that's really important, when we speak about HIV incidence, we're not talking about a curve that we still need to bend. It is very much a curve that has been bent in the past, over the last 20 years, several times over. And that is both by the advent of ART and the rollout of the ART program, as well as of the rollout of medical male circumcision. So we're around about here, and further maxing out oral PrEP would really not do very much to that incidence curve altogether. Now, if we look at this part here in more detail and look at HIV infections averted rather than incidence, we see that there is, in fact, quite a bit of a difference between the different subpopulations. So in pink here, the most impactful intervention would be oral PrEP, or maxing out oral PrEP to young women, or adolescent women rather, between 15 and 19, followed by maxing out PrEP to gay men and other men who have sex with men. In almost all instances, you can see that the solid line of targeting the entire population, so in this case, the young women, is tracked quite closely by the interrupted line of targeting only the people who perceive themselves to be at highest risk of HIV acquisition in each of those populations. That's true for the young women, the adolescent girls, the adolescent boys, the young women, and the young men as well. So In other words, in terms of impact, it's almost as impactful to be targeting or relying on self-targeting by risk other than the entire population. However, this changes completely when we look at cost. So here we see that that doing away with targeting leads to a lot more cost than relying on self-targeting and having only those who will have the biggest impact from the prevention intervention come forward for PrEP. And these are incremental costs, so the additional cost per year over the flat line here of what we are already expecting to pay for the HIV program in South Africa altogether. And these are increasing costs for the next 20 years. However, there's a couple of targeting options, in particular to adolescent girls, especially if it's targeted, as well as to female sex workers, where over the next 10 to 15 years, we would see a reduction in annual costs in the entire HIV program, which would then further out lead to cost savings. How does this change if we look at injectable rather than oral PrEP? This is a more recent analysis that we've done directly working with the people who ran the HPTN 084 trial. That trial, of course, showed that offering injectable PrEP in the form of injectable cabotegravir increases the HIV prevention effect of oral PrEP by 89%. And this, the CI is in fact from the 2-year data presented last year in Montreal. So this was established not just for the first, but also for the second year that these people were offered injectable PrEP. And by 66% in gay men and other men with sex with men, as well as transgender women. As Dr. Neilan has already very much brought to the fore, the cost of cabotegravir as an injectable PrEP option is still very much under discussion. And for South Africa, it's a completely different space that we're in. The current US list price that Dr. Neilan mentioned is roundabout still, I believe, $3,700 per injection, which is, of course, completely unaffordable for any low and middle income country, including a high middle income country like South Africa. CHI has analyzed this, so the Clinton Health Access Initiative, and they think once the capital outlays are taken into account, you could be producing this injectable at a price of $240 per injection. So you can see those are kind of 3 orders of magnitude, 4 in fact, away from each other. So it could be much cheaper. Of course, that's not what the US market is being asked to pay, but where should the price lie for a very poorer country like South Africa? Others have weighted in, and there's a whole big range that was bandied about for the last 15 months. This is important because right now, generic manufacture can officially only start in 2031 when the last of 6 current patents is about to expire. The manufacturer, who shall not be named, has since agreed to giving out voluntary licenses for generic manufacture to 3 companies. They've been announced earlier in the year, I think in April. This will cover 90 countries, including South Africa. It's a charitable exercise brokered by the Medicines Patent Pool. It's all fantastic. However, it will take another 3 to 4 years before these additional companies can start manufacturing, just because it takes them so long to get that up and running. So in this space, also in order to inform that at what price South Africa should accept this drug once this production would start rolling, we were tasked to do a threshold analysis, which similar again to the analysis that Dr. Neilan presented for the US market, involved swapping this formula for cost effectiveness around in order to solve it for the price, the lowest possible price for injectable CAB that would allow it to be as cost effective as oral PrEP. So this is working off the notion that the South African government will be happy to pay for oral PrEP. However, if we have a more effective alternative, what would be the additional price they should be able to accept in order to land at the same cost effectiveness? These are our scenarios, and I won't bore you much, but basically we are looking at, for oral PrEP, 2 different coverage scenarios. We're assuming 5 months of duration. So once someone goes on, they stay on it for 5 months for the young folks and female sex workers, slightly longer for MSM. We have two different coverage scenarios for oral PrEP, 5 and 10% for the young folks. We have the effectiveness that we have for oral PrEP from the trials, and this is our annual cost, lower than what I presented just now, because here we are assuming only 5 months for these folks. For Cabalet, we don't just have a medium and high coverage scenario where we are looking at between 10-20% coverage, going up to 20 and 40%. We also have two different duration scenarios, and that's important. For the minimum duration, we're assuming that everyone who goes onto injectable PrEP will stay on as long as for the oral. For the maximum duration, we're doubling this, or more than doubling this, to 12 months. Once you've started, you will keep going back to the clinic for your 2 monthly injections for 12 months. And this is very much, and your coverage is also higher. This is borne out by the fact that going back to the clinic for an injection every 2 months is much easier than to remember and be motivated to take your oral pills every day. We have a higher effectiveness. The price is very similar per month to that of oral PrEP, and that's just in this analysis where we assumed the drugs cost the same. So again, when we look at the results, the impact on HIV incidence, so this huge curve that starts from up here has now been kind of cut short. It's just our forward projection from 2022 onwards. We can see in green the impact of oral PrEP still as minimal as below, even though, can I just take us back for a second? So this 5% coverage of young people, so everyone below 24, is much, much higher than what we're currently seeing. We're seeing something like 2.5% of young people have ever tried PrEP, and it's nowhere near what we need to have any of these impacts, even for oral PrEP. Anyway, so if we max out oral PrEP, we could be shaving up of 0.15 to 0.16% of incidence over the next 20 years. Really nothing to write home about. We would have a much, sorry, this is not the reduction, this is the remaining incidence. We would get very close to the 0.1% incidence threshold that we need to eliminate HIV in the long run. In terms of infections averted, we'd have up to 3 times more infections per year that we can avert under injectable PrEP. And that then directly results in a reduced need for ART, which is also, again, much, much greater under the injectable PrEP scenarios in orange and red here. And then finally, that translates, or normally it translates also in a cost curve that should look similar to this, given that ART is our biggest cost driver in the HIV program. That is, however, not what we see because of the cost needs for additional people going onto and staying on PrEP that we assume in the injectable PrEP scenario. We actually have an increase in the total HIV program cost that's to the tune of up to 23% more if the price of injectable PrEP was twice that of oral PrEP. And we have up to 60% of young people on, or young women in particular, on Cabalet, which is what we are assuming here. So lastly, as I said, we kind of solved this whole thing for the acceptable price that for the South African HIV program of Cabalet, and we found that South Africa should not pay for more than $9 to $15 per injection maximally, and that depends a lot on the uptake, etc. So this basically what we knew before we started. Cabalet is highly effective at preventing HIV transmission. What we added to this is that it would, if our assumptions hold true, lead to a 3- to 5-fold decrease in HIV infections and AIDS deaths over the next 20 years. We would need the drug to be costing between $9 and $15 per injection for it to be similarly or more cost effective than oral PrEP in South Africa. And that meant that we could add a very thin range, a very tight range to that discussion about the right price for Cabalet that has been raging for about the last 1.5 years. We know by now that there are other challenges for the rollout of injectable PrEP. It's not just the price. Right now, the biggest problem is the manufacturing capacity of the sole manufacturer, which isn't quite up to demand. We also have to create enough demand for Cabalet in those populations over the next 2 years to see anywhere near those effects play out. And probably by the time at least when a generic manufacture will start, we will have to have cost share arrangements to bring the cost even further down than is currently envisaged, even with generic manufacture. So I want to round off with one last intervention after talking about PrEP so much. We also did a very small little analysis looking at the impact, the potential impact of a condom, especially branded and targeted at young people. So here we looked at the impact of distributing, on top of the 1 billion condoms that we're distributing in South Africa every year, another 100 million youth condoms to 15 to 35-year-olds in two different ways, either with standard condom specs. And for those of us not in South Africa, we have a government branded condom. Sorry, I shouldn't be smiling. It's called Max. You can have it in 4 different tastes and colors. So this condom leads to a situation where in the model, we have to assume that for 3.45 condoms distributed, 1 condom is used. So basically, we're wasting 2.5 condoms for every condom that is used to protect the sex act in order to make sense of both the huge amounts of volumes that we're distributing and the still resulting incidents. We also then looked at a different scenario where we assume much increased effective use in young people of these condoms, basically reducing as a result our condom wastage to either every condom used or 2 condoms distributed per 1 condom used. And long story short, what we see, and that's just over the next 5 years, even though it would continue into the future, a reduction of new HIV infections of between 12 and 31% if every condom distributed was in fact used to protect the sex act. If we had a very small proportion of our current condom volume specifically branded, so they would be desirable to young people. So in summary, and I know this has been a lot of numbers and all of them all over the place, but in summary, what we saw right at the beginning is that youth-targeted HIV interventions are not the most cost-effective interventions for the South African HIV program. If cost-effectiveness is what you're after, then there's a whole number of other things that trump them, including increasing condom use more generally, increasing ART coverage, especially retention, especially of slightly older men, and testing and PrEP for gay men and female sex workers. But youth-targeted interventions could be very effective and impactful. And just to remind you of just how impactful, we showed that new HIV infections in South Africa could be reduced by 8% if maxing out all PrEP, 15 to 28% if maxing out injectable PrEP, and 12 to 31% if maxing out desirable condoms, if each of those interventions was heavily targeted at young people. And that 31% in particular, similar to the 28 here for the injectable PrEP, we've never seen this in all our modeling over 15 years, that a single intervention, albeit at high coverage levels, would be possible to use. We have also seen that the high uptake of any new intervention would increase the cost of the HIV program in the short term, especially if we want to do things differently and better than before. However, and I'm just projecting these kind of bendy cost curves again, the additional cost per year, which is what we're looking here, will decrease after 7 to 15 years, and that's true across interventions, depending and how quickly it bends depends on the uptake and the success of each individual intervention. Thank you very much.
Thank you very much, Dr. Gesine Meyer-Rath. Wow, this is quite a lot in the sense that sobering somehow, yeah, that our adolescent intervention could be very impactful, but in terms of, are they the best in terms of reducing this? They rank low at number 4 or 5 after many other, including better use of condom with less wastage. So thank you very much. I'm looking at the time and being aware of the time for everybody and giving people the time to ask questions. Why don't we just do then the next thing, which is to introduce the panelists and then give them the floor, and after that, we'll then have the questions from the participant. So please allow me to first introduce the two panelists, Professor Lungiswa Nkonki of the Department of Global Health, Stellenbosch University. Her research interests include economic evaluation of healthcare intervention, kind of thing we've been doing, particularly the cost effectiveness of community-based intervention to improve maternal, child, and adolescent health outcomes, measuring inequalities and inequality in health outcome, social determinant of health, universal health coverage, and private healthcare. We're also been joined by Cheryl Hendrickson, who is the researcher at the Wits Health Economics and Epidemiology Research Office since 2014. She holds a master's in public health from Boston University and has over 4 years of experience in quantitative, qualitative, mixed research method for global health programs. Before joining HERO, Cheryl worked with international nonprofit organization that focus on sexual and reproductive health, where she provided technical support to the research, monitoring, and evaluation efforts for programs in East Africa, specifically Ethiopia, Kenya, Uganda, and Zambia. Welcome, Professor and Cheryl. The floor is now yours.
Okay, thank you, Chair. I'll go first. Thank you to all the participants and the speakers. First, I really wish to congratulate both speakers on excellent presentations, and it's really encouraging at this point to be able to be in a space where we are seeing evidence, health economics and evidence being used to inform decision making. So I think I'm just going to comment on two things from the first presenter. I think that for me, the key takeaway message, which I also think was touched on the second presentation, is that there is a space at the global health community to begin to lobby and use the evidence that we have that has been generated through these types of studies to actually lobby for a reduction in the price of CAB-LA. I think we have some very important lessons with ARTs for the adult population, as well as in early times during PMTCT, where there was significant global lobby to reduce the prices of ARTs, and that took different forms, whether it was through extension of patent licenses and various other platforms. So I do think that there is an important key message that CAB-LA is an effective intervention, potentially cost-effective intervention at a certain price range. And I think that as a global community, if we want to prioritize global health, we have evidence to begin to inform that space. Then I just wanted to touch on the issue of thresholds. So I think the first presenter showed us the threshold for the US context, and just wanted to remind people that in many middle and low income countries, actually countries do not have a defined threshold. There still is a usage of the WHO guideline on interventions that are 3 times the price of GDP, and that creates in many low and middle income countries a very contested space in terms of which interventions can be adopted or not, or should be prioritized or not. Then I'm going to move on to the sort of South African, the second presentation, which I very much liked, also the ranking of interventions and showing which interventions are more cost effective if we're looking at allocative efficiency. And here I want to comment on the issue of uptake and how uptake for adolescent health programs in particular is challenging, which I think didn't come through in both intervention presentations. So I think that most interventions for adolescents, they're challenging to be delivered. Either they are delivered at the school-based, and in some instances, there are various methodologies to try and attract adolescents to health facilities. But in many health facility settings, adolescents do not feel welcomed. And this has an impact when it comes to the implementation of interventions that have been shown to be cost effective. But when it comes to the delivery and how many people adolescents can actually receive the intervention, that becomes a challenge. So I think that the next phase of research in this space does need to focus more on what do we mean by community mobilization. I saw on one of the slides in the second presentation that community mobilization was not a cost driver, but what type of community mobilization was employed there. And I think that within low and middle income countries, gender norms affect access and uptake of adolescent health programs more than we are able to understand in many instances. So currently, we've just completed a systematic review looking at economic evaluations of gender transformative interventions that are aimed at adolescents. And so I do think that we've reached a point looking at these presentations where we've done the first in-depth level of generating economic evaluation evidence of, do we have this interventions, in particular CAB-LA as a relatively new intervention with promising cost effectiveness potential. But the key question is, in our settings, how could, at the right price, how could we increase uptake? And how can we increase uptake of existing interventions within the delivery platforms that we know are most suitable for the adolescent health population? And I think I will pause here and hand over to the next panelist. Thank you.
Thank you, Lungiswa. I think that was, you made some excellent points. And I would want to add that, thank you to the speakers. I think it was very interesting to hear from the modeling perspective and the cost effectiveness perspective of these interventions. My area is specifically in HIV prevention in the biomedical space. So that's probably largely where I will touch on. But I think it's very exciting to see these analyses that are coming through and showing that these interventions can be cost effective, maybe not necessarily the largest drivers of decreased incidence, but potential to have significant impact. And as Lungi just mentioned, I think one of the exciting things is that, at least in South Africa, we're currently going into sort of this next phase of implementation projects and seeing how these new mechanisms can really behave or perform on the ground. So there are a number of projects in South Africa that are kicking off at the moment that will specifically look at CAB-LA, within adolescent girls and young women and other populations. So I think in the coming few months and years, there'll be great data that will come out. They'll sort of demonstrate how Cabaret and other modalities really function on the ground. And I think from an economics perspective, this is going to allow us to really gather some, as Gesine mentioned, some bottom-up resource utilization data that can then give us a sort of more accurate sense of the costs of these interventions, and then can be used to feed into these models that have been developed to see what comes up with, what they come out with some more detailed on the ground data. So I know there's a number of projects, including the Desmond Tutu Health Foundation, are on the go in terms of Cabaret. Also the Depivarine ring, which we haven't mentioned, but that'll also be an offering, as well as obviously oral PrEP. And I think the other exciting aspect of this next phase is also going to be, looking at what choice offers. If young people or anyone who sort of could benefit from being on PrEP or other HIV prevention technologies, what they can actually, what'll happen once there's a lot, choice. We know from the field of contraception that choice plays a large role in determining uptake. And so that's one part that I'm really excited to see coming on board as well. And I think another thing just to highlight, probably because it's my sort of area of interest, is now looking at the detailed costs. So Lungi mentioned, mobilization and demand creation. And I think, we've seen through the oral PrEP program in South Africa that uptake has been suboptimal. I think there was large hopes that this program, that this offering would really have a large impact, and we've seen that hasn't necessarily been the case due to sort of low uptake and low continuation. And so I think there's lessons to be learned, particularly amongst the adolescent populations, around how we can then, when it comes to introducing Cabaret and these other HIV prevention modalities, what can we learn? What needs to be done from a mobilization and demand creation aspect? And then how that does contribute to cost, because I think it's something that's difficult to measure, but I think it is something that will actually play a large role when we talk about the costs of these programs and of these interventions. I'm going to stop there as well in the interest of time, because I'd love to hear from some of the participants. But again, thank you to our speakers. It was really fascinating stuff that you presented. Jessica, am I handing it back to you for asking questions?
Yes. Thank you, and thank you very much to both the panelists and the presenters. Very interesting, very insightful. There are questions in the Q&A. Some have been answered, some not. So maybe we can start with those. For Dr. Gesine, related to youth condom, are there other differences assumed for those condoms apart from their branding, like lubricant, scent, thickness? For both speakers, how sensitive are the results? And then here's someone, have this study examined the spillover or secondary effects of implementing these interventions? I may have missed it. Those are in the Q&A.
Jessica, you want us to go ahead and answer?
Yes, please. Can you start while we're getting other questions? Yes.
Great. So I'm really sorry, Mr. Ross, I'm assuming I have typed a long answer to your condom question and it has disappeared, which fills me with dread. So I can't type it up again, but essentially for the condom analysis, we did not assume any specs. We didn't even cost it because it was a very, very theoretical analysis, really, to just see if we had a use condom that increased effective use amongst young people, and a very limited volume of these condoms, what could a theoretical impact be? And it was really just kind of, we did it while there was a youth condom tender out, just to kind of keep that momentum going, that after, after years, almost a decade of South Africa spending money on 1 billion condoms every year, that there's still space to actually do a better job, not just to have volumes, but better condoms that kids actually want to use. In summary, there have been a number of surveys that kind of actually summarize what kids want. And in summary, what they seem to want is choice, like anyone else, I suppose. Any of us who are using condoms, choice when it comes to flavor or none, or scented or none, choice when it comes to thickness. And what they actually want is branded condoms rather than the kind of government issue one size fits all virtually, but for different tastes. Again, like the rest of us, they just want high quality branded condoms. The question I've answered, I think, the questions about the time horizons. And the paper actually has a huge, big probabilistic sensitivity analysis that does everything apart from the discount and the time horizon, which is why I answered those in particular. And then the question about spillover secondary effects. So I would imagine that the person who asked this was asking perhaps specifically about secondary infections that are being averted. So not just the ones in the people you're targeting or who are on the PrEP or the other interventions, but also secondary infections that basically are being prevented in those people they could have passed infection onto. And for our model, the Tembisa model, absolutely, yes, that's exactly why effectiveness compounds over time. So we have a whole tree of infections that we are averting, essentially. And I know just from studying the CPEC model in detail that that is true for that as well. So if those are the spillover effects, yes, we incorporate them. And that's exactly why we're seeing more and more of an effect over time.
Thank you. Thank you, Dr. Gesine. There's a question for both of you, and that was, how sensitive are the results, Dr. Neilan?
So I just want to echo everything that Dr. Meyer-Rath said. So thank you for articulating and addressing all those so clearly. I think there are a lot of similarities to the replies that I would have. So Jessica, I think you were saying, hopefully just to address specifically discounting future benefits. So in the CPAC model, I think that's from Dr. Rath, we use a 3% discount rate. And we vary that in sensitivity analyses, and it is not particularly impactful for the policy questions that we were answering there. I think generally, if you don't use a discount rate and you're trying to say something is cost effective, it's not necessarily a conservative assumption you're going to inflate the benefits of your intervention. So it's sort of, I think one of the practices that we take in cost effectiveness analysis is trying to kind of, one of the beauty of models is that you can vary in a way you might not in a live study, kind of what is going to undermine your assumptions. So I think so that's one of the strengths of models. And then for the time horizon, again, I think it sort of depends on the assumptions. So if we consider the benefits of preventing a single infection of HIV for a very young person, if you limit that horizon to 10 years, well, then you're underestimating the benefits of averting that infection, because a person would have a lifetime of costs associated with living with HIV. However, if you're looking at a prevention program and you're really modeling the churn of people coming in and out, and over time HIV incidence is declining, but perhaps you have more and more people on a very expensive PrEP modality, it might be flipped. So I think it depends on the assumptions you make about the horizon, and I hope that answers that question. But in general, we've tended to the shorter horizons for many of our analyses, because as Dr. Meyer-Rath kind of articulated really nicely, like who knows what's going to happen 15 years from now. So to examine it over both is an approach we've taken, and generally we've been able to sort of demonstrate what impact different considerations over the horizon would be. So for a lot of the adolescent analyses, things look better over time. I think I ticked off those questions. Jessica, were there others that I might have missed?
No, that's just one that just came, and it says, have this study examined the spillover? Oh no, that one has already been answered. And okay, no, the rest that are here have been answered. So I can't see any new questions. So since there's no new question, maybe we can give the floor to get the poem if it's still possible. I can't. Okay, so Dr. Gesine, you want to talk? Please go ahead. I can see your hand.
Thank you. I just wanted to very briefly say something about, if I may, about the point raised by both the discussants, in fact, about the uptake, especially in adolescent folks, and what our models show that is of relevant in demand creation and planning for this. I think what can't be overstated is the difference that we, as well as the CPEC team, found in the potential difference between oral and injectable PrEP. Oral PrEP, I think we've all been felt a little bit let down by, because there's a fairly high uptake in certain subpopulations in certain situations, but it's really not anywhere near where we need it to be. I do think we've screwed it up from the supply side, from the way we rolled it out. I think it was much too slow, and it was first to a highly stigmatized population. So by the time it was available in a PHC clinic near you, people already knew it was only for people who actually had a lot of risk. And I think there's a couple of lessons there that we really need to learn very quickly before we embark on injectable PrEP. I do think injectable PrEP needs to be available wherever you need it without questions asked. You don't have to prove that you're actually at high risk of acquisition. You should be able to access it quickly, get those 2 monthly injections without much cost to yourself. If we can bring it to the community, even the better. Whatever we do, we need to be cognizant of the fact that injectable PrEP for the foreseeable future is not only our only option, HIV and prevention option, but probably the last one that can actually make a huge difference. And I do think we all need to, I don't normally kind of talk about policy, and I'm not an advocate, but I do think we need to bring all forces to bear, both on the funding side and on the planning side and on the community and the advocacy and the demand creation side, to make sure that injectable PrEP is an option we take seriously, and everyone gets access to as quickly as possible, as soon as the price issue is figured out. And that's probably sometime this year or next. So get ready.
Thank you. That's good news, that by the end of this year or next, we'll get the price issue fixed. Because really, the good thing with PrEP is that as an adolescent girl or young woman, you're the one who controls it, rather than you're asking someone to use the condom, and they may not. But in this one, really, you can even get it very discreetly. If it's an injection, you go, you get out, and nobody knows, in terms of stigmatization and all this. So thank you so much. I think at this point we'll have the poem ready. I think in between it was ready, so maybe, yes. Volumes.
Hi, my name is Hope Nadine. I am a writer, poet, and performer from Pretoria, Gauteng. Today, I'll be sharing a poem in regards to the topic health economics and how they impact the lives of young Black women in South Africa specifically. Ma, please don't die yet. Give me another day to beg for a lifeline. Mr. Manager says it's coming. It might be lost somewhere in the power lines, but it's almost here, but please, borrow me your lungs again. I promise not to give them away this time. Mr. Manager says I need them just one last time. Then Uma can live to see another forever, man. Mr. Manager has disappeared again. I forgot he's a magician. He shows up only when I'm desperate enough to keep you alive. His magic is stronger when you're facing death in the eye. Mr. Manager, I have nothing left to give. If you could just forgive my naivety and grant me life. It's my turn to give life to my family. Please, grant me the power to let my family see me live. Please, grant me enough to bury my mother right.
Wow. Wow, wow, touching. Okay. Thank you. That was very powerful. Okay. Just a few minutes to go. I can't see any other hand up. So maybe with your permission, we can wrap up if there's nothing else burning. Then thank you. Thank you everyone so much for attending today. We have a very large turnout. We're now 67, but at some point we were beyond 90. So thank you. Thank you so much for being here. Thank you for attending. Thank you for your interest and your questions. Thank you, speakers. Thank you, people who sent questions. Thank you, panelists. Thank you, artists. Thank you, DTHF, and of course, IAVI for sponsoring this event. Thank you. Thank you so much. Please note that as you exit the Zoom platform at the end of this webinar, a very brief evaluation will pop up. We'll appreciate if you take a moment to complete it. Your feedback will help us improve this webinar series going forward. This session has been recorded, and soon it will be available to view on the DTHF YouTube channel. Thank you. Thank you again. And please don't forget to answer the poll at the end. Thank you.